So this patient is a 50-year-old female. She's a malpractice judge. So I don't know how common lawsuits are in India, but in the United States, dealing with lawsuits as a spine surgeon is one of our biggest pain points. And this patient herself is the judge of a lot of these malpractice suits. Now, she presents to me with a long-standing history of neck pain. But she specifically is coming in now with upper extremity radiculopathy symptoms that are new to her. And she does find that they are worse on the left than the right. But she's also starting to describe some problems with balance and dexterity. And obviously, she's a very smart woman and knows surprisingly a lot about spine issues from her position as a malpractice judge. And so she comes in saying, I already saw a neurologist, they are concerned about my cervical spine, and I think I need cervical spine surgery. So, this happens very often, I'm sure here as well, when patients are very educated. Now, on her physical exam, it's pretty benign. She's got some mild strength loss. She does have some sensation reduction to light touch on her hands. But her tandem gait issues are pretty significant. She has a very hard time with tandem gait. Her reflexes are slightly hyperactive. And luckily, if she hadn't seen a neurologist, I would have referred her to a neurologist, but she's already seen a neurologist who has ruled out any other sources of issues. So that's the patient that we're dealing with. And here are her radiographs. This is her cervical spine radiograph, and then this is a standing long-length film that we do very often called an EOS film just to assess for alignment. But on her standing films here, we can see multi-level cervical spondylosis, primarily affecting the subaxial spine starting at C4 and going down to C7 with a subtle C7-T1 anterolisthesis, as well as a C3, C4 kyphosis and spondylosis. So a lot going on, similar to what we've seen. And then this is her CAT scan. I like to get CAT scans on most of my patients just to assess overall, as I'm thinking about how best to treat this patient. But we can see sort of, pretty significant disc disease and uncovertebral arthropathy, primarily affecting C4, 5, 6, and 7. And then here is her sagittal view of her CT scan. Again, a nice way to assess the facet joints and being able to see essentially these 3 levels that are primarily affected, 4, 5, 5, 6, and 6, 7. And then I'll just shift forward here to the MRI. And you can see for yourself here that the cord compression I would say is not severe as I just roll through here. Sorry, I'll start at the bottom. So this is T1, there's 7-1, nothing much going on there. Here's 6-7, so some loss of cerebrospinal fluid ventrally. C5-6, we can see a disc fragment sitting in the foramen. And then C4-5, again, just, some foraminal stenosis. So really a mixed picture with some cord compression at one level, foraminal disease and radiculopathy type of issues or nerve root compression issues, at a couple of other levels, but in a patient with this very kyphotic cervical spine and worsening symptoms. So I'll stop there for a second and let's just talk to the panel about treatment options. So let's just start at the beginning, closest to me here, with regards to. Tell me, do you believe this patient has myelopathy first and foremost, and based on the MRI findings? And secondly, if you were convinced, how would you treat this patient?
She obviously has a myelopathy that is. Only thing is, before this thing, do you have flexion extension views?
I do, but I didn't include them in this slide only because, in the presentation. But let's use this as a surrogate for our views here. But this is her standing radiograph, and this was done probably 1 year prior to this film here, which I know is a little harder to see. but if you'll just give me the liberty
No, I just want
to
to
prove to
know
you that
on
she has some
flexion
worsening.
extension view whether
Yeah.
the kyphosis is increasing or stable.
It only gets to as good as this X-ray. So yeah, this is the best that it gets right here.
In this situation, I would prefer doing, see, kyphosis is there, but not, first standard is not really bad. Early symptoms of myelopathy. I would do posterior laminectomy with stabilizer.
Posterior laminectomy with fusion. Can we go to the, yeah, we'll just go down the line if you can just tell me what you would do.
Yeah, just one thing. I think she's got a tandem gait, and obviously, I think it looks cervical myelopathy only. But I think we should rule out the bottom one also, means the dorsal and the lumbar thing. I hope it is clear. So there is no
Yeah, she had
issues.
lumbar MRIs done, which were normal. Thoracic imaging was not performed, but she was referred by a neurologist. But yeah, we had talked about potentially the need for thoracic imaging.
So, in my opinion, I think she's got a radiculopathy as well as the myelopathy. I think there is a kyphosis. I think I would definitely prefer to go anterior. I would go all the way from C4 to C7, doing anterior discectomy, plating, and the caging.
Okay, so you would do, so we have one for posterior laminectomy fusion, one for multi-level anterior cervical discectomy and fusion. Can we just keep going down the line to hear the next three? You could just tell me what you would do.
Slightly dicey, but if she has been cleared by the neurologist that
Yes.
nothing medical is going on,
Correct.
so she has clear symptoms of myelopathy, so I would like to operate. But I would be joining forces with sir. So the kyphosis is there, but it's not that bad. If she's not going into further kyphosis in flexion extension X-ray, so I'll just go posterior, decompress it, and stabilize it.
Okay, so you
If
would
she is
do a
getting
fusion.
an extension, I would like to go in slight extension, or at least I'll fix it in neutral. So
Okay.
that's fine. Fine
Okay.
by me.
So posterior decompression and fusion.
Yeah,
Okay.
posteriorly.
Yeah. Can I see the MRI imaging?
Yeah, sagittal MRI, do we have it?
So
I just wanted
I
to ask
have it.
that.
I didn't include it just for the interest of time. But yeah, let me just run through again. So again, we'll go to the bottom here. Start at T1, work our way up from T1. So that's 7-1, which I felt was clear. 6-7, I thought she had a little bit of that cord impingement and rotation. 5-6, she has a little cord impingement anteriorly with that left-sided herniation. And then C4-5, she just has this foraminal stenosis on the left side. And then 3-4 and 2-3 look pretty good as far as her, as far as the neurologic elements go. And then this is her CT scan, so you should see severe degeneration 4-5-5-6-6-7 with the 3-4 spondylolisthesis, 7-1 spondylolisthesis.
So I'm a bit skeptical regarding the myelopathy originating from the cervical spine because the images are not suggestive of that.
Yep.
So I would treat her rather for the radicular symptom and investigate her further for myelopathy, probably from the thoracic or some other reasons for it. And I would treat this patient anteriorly 3-level ACDF with tackling the osteophytes posteriorly, which is the cause of the radicular also, along with the disc. And that would be my surgical plan, depending on the information I have available right now.
Okay. And last,
Yeah. Predominantly, this dorsal column involvement is there. Balance in the gait. I'll prefer to go by posterior approach only.
okay, perfect. And you would do posterior decompression alone or with fusion?
Yeah, I'll do decompression along with fusion.
With fusion.
Instrumented
Okay.
fusion.
Okay. So interesting. Everybody went with fusion. How common is laminoplasty? I'm just curious. Are you guys doing any laminoplasty in your practices?
Not true.
Not routinely. Okay. So yeah, I mean, for me, I'm not a big laminoplasty user, but I often think about it as an option, especially for motion preservation. I thought this patient had too much kyphosis for laminoplasty, and it's a little unfair because I showed you this current X-ray, which is the one that's harder to see, shows that there's been a pretty significant progression of her kyphosis, even compared to here. This other X-ray that I showed you. And I was also very uncertain about her myelopathy, but I felt like because she had seen a neurologist who had said there's nothing else going on here, I thought that one of the things that sometimes happens is, especially when patients stand, the kyphosis accentuates, and then the draping of the spinal cord over these anterior osteophytes can be significant. So, so I'll just jump to what I did. Again, I think a very controversial surgery. I did a 2-level disc replacement with a single-level fusion. And the reason I chose, I had a long discussion with this patient, and I said, look, there's nothing I can do that can guarantee you that you won't need another surgery. Maybe we should include C3-4, maybe we should include C7-T1, but the areas that I think have to be done are 4, 5, 5, 6, and 6, 7. I probably would have done a 3-level arthroplasty on her, but it's just not approved in the United States for use at 3 levels. And we had that discussion with her as a judge. So this is what we did. This is her 3-month follow-up x-ray. I just recently did her surgery. So you can see pretty nice restoration of her alignment, and she's had a pretty good result, very short-term result so far. But you can see C3-4 and C7-T1, continue to be a little bit kyphotic and listhese. So that, I think that's what time will tell what will happen. But I thought, interesting case, not a surgery that not an approach that I choose very often, but I thought in this case with a lot of nuances, I was able to avoid a multi-level fusion and avoid a plating in the front and avoid the neck dissection for a posterior surgery. So thank you very much.